Well, good afternoon now. Thank you to ICS for inviting me. And I guess a thank you to SUFU for allowing me to be the SUFU speaker. So since I started at USC, I spend 2 days a week at Rancho Los Amigos, which is one of the top 10 rehab facilities in the United States. And because of that, we see a lot of patients, obviously, with a variety of neurologic issues, including spinal cord injury. As you can see here, we have a very robust spinal cord injury games and athletic program. And this is a picture of Rancho Los Amigos now. And this is when it first started in the 30s. And if those physicians are sitting where they are now, they would be run over by a multitude of cars, because that's now a street called Imperial Highway, which is a very busy road. So we've evolved a bit since this place first got started. This group knows a lot about voiding dysfunction. We know that no matter what it is, what your neurologic diagnosis is, you have a high significance of having some type of bladder dysfunction. Why do we care about neurogenic bladder? Well, from a physician perspective, really our main goal is we want to keep your renal function optimized. I tell our patients, if you're a spinal cord injury patient, you're a urology patient for life, and my main goal is to protect your upper urinary tracts. What do patients really care about? They're not usually concerned, what does my renal ultrasound look like? What's my renal function? They care about, are they leaking when they don't want to? Am I having bladder infections, among a variety of other issues that may impact them? But really, all of these issues, whatever they may be, impact decisions that are made as to how we manage patients. And another important impact is hand function, and how good that hand function may be, and that's what we're going to talk a little bit about today. So there are a variety of ways we categorize neurogenic bladder, and certainly one is to look at issues above the brainstem. We know they have the detrusor overactivity. We look at spinal cord injury issues, suprasacral spinal cord injury. We know they have detrusor overactivity with or without sphincteric issues, or more distal issues. Another way that we like to classify is the classic failure to store, failure to empty, problem with the bladder, problem with the outlet. And this is what I talk with my residents with all the time and fellows. When we have a patient, is it a problem to store with the bladder? This is how we're going to treat it. Is it a problem with failure to store with the outlet? This is how we're going to treat it. It allows you to really focus on your treatment. Is it a failure to empty with the problem with the bladder? Again, this is how we're going to treat it. Or the same thing with the outlet. So what is the common thread with all of those treatment options? And the common thread is the use of clean intermittent catheterization. So we owe a great debt of gratitude to Dr. Lapides, who first introduced this. And he first introduced this in 1971. And when you look at the 100th year anniversary of the Journal of Urology, this was republished in that anniversary when he published his really seminal article in 72, but then again follow-up in 218 patients in 1974, really brought to us the importance of clean intermittent catheterization. And if you look at really one of the fathers of neurogenic bladder, Ed McGuire, had editorial comment in one of these articles that said, we owe Dr. Lapides a great debt. This brief article is a record of enormous contribution to our knowledge, saved the lives of countless patients, a revolution in urologic care which continues to evolve, which we continue to embrace to this day. So here's a very typical patient. 34-year-old T4, he's leaking despite oxybutynin. He's not probably catheterizing enough. He has symptoms of dysreflexia, getting sweaty prior to his incontinence episodes. And you look at his study, he clearly has detrusor overactivity, sphincter dysynergia, has that classic spinning top view on the video study. And how are we going to treat him? We're going to manage him with medications and or botulinum toxin with clean intermittent catheterization. So what if you have the same urodynamic findings in a patient with C4 injury who can't do his own catheterization? What's going to be different there? So before we delve into that, I think there are two questions that are very important for us to look at. So assuming the bladder storage pressures are safe, or we're not putting the upper tracts at risk, what do neurogenic bladder patients prefer in regards to the management of their lower urinary tract? CIC, indwelling catheter, or something else? And what should we do for those that aren't able to do catheterization, and is it different in men versus women? So what do the guidelines tell us? Well, EAU says intermittent self-cath is a preferred management method. Canadian Urology just came out this year, and will say, well, every attempt should be made to use the gold standard of CIC. So there, you can see it saying we want to use it, but some patients may not be able to. AUA, we should be having this out in our annual meeting, and hopefully you'll be there to hear that presentation. What do the patients tell us? Patients actually tell us something maybe a little bit different, and it's not completely clear. I'm going to look at two different studies. So a Dutch study looked at 282 patients, and I want you to appreciate both of these studies had patients that were very mature in regards to their injury. Median time since injury was 22 years. This is a very unique group of patients, and they evaluated in terms of what patients prefer in looking at the quality. And remember, the lower the score, the better. And interestingly, the patients with the lowest score had urinary diversion. And in the middle were patients that were avoiding normally, condom cath or CIC. The patients that did worse were the ones with indwelling catheter, which may be a little surprised that the patients that had diversion did best, but I'm not surprised the patients with indwelling catheter did worse. What's the other? The other study came from Inbridge, Neurogenic Bladder Research Group, which I'm happy to talk to a little bit because this is a group that I'm a part of, but I'm a very older member. I don't think of myself as old, but I'm an older member of this group, and there's some really young, dynamic researchers that are going to be leaders in the field in the future in the world of neurogenic bladder. And this is a study that's going to be in Journal Urology and looked at a significant number of patients. This is all surveys, patients answering online or doing surveys at a variety of offices. And the outcome was the neurogenic bladder symptom score with 4 domains, ranges 0 to 74. And again, the lower the score, the better. So who did worse? Patients that are voiding, and that includes those that are reflex voiding and condom catheter. But who did best? Patients with an indwelling catheter. That was very much a surprise. Patients with indwelling catheters. So what do our patients prefer? The answer is I'm not really sure. And we'll talk about how this is a little bit of a challenge when we try to decide what's best for our patients. So let's go back to this scenario. What if we have these same findings in a C4 male? So I would say these are our primary options. And I would say that CIC done by others to me is preferable, but often not possible for a variety of social reasons. I'm trying to avoid indwelling catheters if I can in most patients. Going right to a conduit's a pretty significant big surgery for my first step. And just putting someone in diapers doesn't resolve issue of potential pressures, dysreflexia, whatever it is. So we're often doing condom catheter, maybe a sphincterotomy, something along those lines. So when I came to Rancho Los Amigos in 1997, patients got the operation. I'm like, what's the operation? And a lot of patients at that time were getting, you just get a bladder neck incision, external sphincterotomy. We took care of both sphincters. That was what people were doing. We could take care of both sphincters. We're going to lower your pressures. You're going to reflex void to a condom catheter if you're a male and you can maintain a condom catheter, and your pressures are going to be low. But the question is, does this work long term? And certainly, I'm not sure that's going to be the case. So this is a good example of this. This is another one of patients we had for a long time who was injured in 82. He had a condom catheter. He had a variety of sphincterotomies. He did well for several decades. And then he began to require catheterization by his brother, who wasn't always available. An SP tube was placed, getting recurrent UTIs, multiple admissions for sepsis. So we've all moved to electronic medical records in the States. I'm not sure where you are, but so I went back and got all the old records, and I had I may get mesothelioma for getting asbestos for looking at all these charts over the course of time, who knows? But essentially, looking at all these studies over time, this is where one of the early studies I could find where he had the true zone overactivity at a pretty low volume. And if you look at what happened with Mark over time, he's still having the true zone overactivity. And in this study, we had a video study. He's got a wide open bladder neck. He's open. But the last study, he's got now essentially an areflexic bladder. He's open, but he has no detrusor overactivity, nothing. So two questions. One is, how does this happen? Is there some kind of neurologic plasticity? I don't think so. Is it just chronically leaving more urine behind and getting over distended? Probably, but that wasn't the goal of a sphincterotomy. The sphincterotomy is allow you to empty out completely. And what are you going to do next? This gentleman ended up undergoing just a simple cystectomy and a conduit. And we'll come back to him later as well. So if you look at sphincterotomies, you always say, the success rate or the failure rate, depending upon how you want to look at, the rates range from 40 to 60% when you look at the literature. So, one of my questions is, when I looked at this initially, is what's the definition of success in these surgeries? I think part of the challenge is we're doing the intervention for a variety of reasons. Are we intervening because of urodynamic issues? Are we intervening because of maybe anatomic interventional issues, whether it's upper tract function, hydro, reflux? Are we intervening because of dysreflexia or UTI urosepsis? So maybe the problem was we're not looking at the right outcome. So I had a previous fellow look at our patient population, and we thought, well, what if we look at, and this may be a little small to see, but we essentially looked at each patient that we operated on and defined the success as to why we intervened. So if the reason we intervened was for elevated true oblique port pressure, did we make that better specifically? And the reality is, no matter how you define success, it's pretty much the same. It's 46%, whatever it's going to be. It works, but certainly doesn't work for everybody. So what about indwelling catheters? I think it's somewhat of a love-hate. For patients that do well, they love it, right? It works, you change monthly, I don't leak, protects the upper tracts. But for patients that aren't doing well, they don't like having a foreign body, issues of UTIs, hematuria, stones, a small risk, but certainly a risk for tumor over time. If you have a urethral catheter, you can get urethral erosion, which is not so pretty. Variety of potential issues. So if we look at the study from Enbridge and the best quality of life outcomes, maybe the question is, should we be placing indwelling catheters sooner in the management of our spinal cord injury patients? So we talked about what if it's a male patient, what if it's a female patient? Or patient with MS, or whatever the neurologic issue may be. Because having CIC done by others is even more difficult for a female patient. There's no condom catheter that's going to be sphincterotomy. So we're left with suboptimal options. And a lot of these women often get managed with indwelling catheters, and the problem is a lot of these women aren't being managed by folks that are here. So then you end up getting a urethral catheter, and you end up with this scenario, right? Where we've all seen this, where you have this big patchless urethra and essentially, or no urethra at all. And that becomes a very challenging problem. And that leads to the need for lower urinary tract reconstruction. So what are our options with lower urinary tract reconstruction? We can do a conduit. It's easy, doesn't require catheterization, and there is not a lot of data in this in the neurogenic bladder world, but one French study looked at patients, mostly MS, some spinal cord injury and others, both men and women that underwent conduit with the primary issue of a neurogenic bladder, and they're looking at the quality, and they saw a variety of improvements in quality of life. Which then again raises the other question, if we look at the Dutch study, and the improvement seen in quality of life, should we be doing lower urinary tract management earlier in these patients? Because theoretically, they're doing very well as well. So going back to my guy, the guy that I had that did well for decades, and then we ended up doing a cystectomy and a conduit, would we have avoided numerous issues sooner if we'd gone to a conduit sooner? Should we wait too long? Should we just gotten this immediately? Well, that raises the other question. We see a lot of conduits, but more so in bladder cancer patients, right? Bladder cancer patients are older. Half of them are going to be dead from their disease within a couple of years, and the others are already older. So how do conduits do over the course of time? Well, this is a study looked at bladder cancer patients. That's what we had to look at. But we know that over time, conduits have issues as well. That's not a free shot either. Example of this is one of our bladder cancer patients who had a stomal stenosis and had this very redundant limb. So conduits as well aren't necessarily a free shot. So we have conduit as an option. What about catheterizable stoma, construct a catheterizable stoma. I ask every single woman that needs a reconstruction, it'd be easier for me to make a stoma for you. Because a lot of women will say, I can catheterize fine at home. When I'm out, having to catheterize in a wheelchair is a big issue. Patients with poor upper extremity function that can't necessarily catheterize their native urethra, but can catheterize a stoma or a badge urethra, and this is an example of a badge urethra. This one you already saw. This is a male with perineal pressure ulcer. Anus here, and this is a catheter in there with the pressure ulcer growing right into the perineal urethra. I can't fix this. I don't think anyone can fix this. We have to now do some kind of supravesical diversion. So this is an example of another one of our patients. This actually was a PhD. He worked at Rancho Los Amigos with me. He had his outside care elsewhere, had multiple sphincterotomies, and was having issues with recurrent urinary tract infections. And his urodynamics was not unlike the other patient, where he essentially had very poor contractility, leaving urine behind. He wanted independence, and he did not want an indwelling catheter. And we ended up doing a bladder neck closure and an augment and a stoma, and you can see how Andy catheterizes here. I mean, it was amazing how he became independent. He would open up his catheter bag using his teeth. He catheterized in this manner, and it worked out great for him, but you have to pick the right patient, But so we've looked at our patients who underwent reconstruction with poor upper extremity function, and we did this. We had 21 of 28 patients we can evaluate, followed up for 5 years, and the majority, 20 of 21, maintained catheterization schedule, and they did very well in quality of life, albeit I would say at this time, there was no specific quality of life measurement to evaluate neurogenic bladder. It was suboptimal evaluation for sure, but patients for the most part very happy. This is a place where occupational therapy I think is very helpful. So we use occupational therapy a lot in regards to evaluating hand function, and especially for patients that can't necessarily catheterize per their native urethra. Can you catheterize a stoma? Is this someone that we can think about? So these are some other old pictures from my institution, and you can see this was in the 1930s when they first started the rehab facility. This was the occupational therapy back then. These are men working on some wicker baskets and doing some weaving. That was the old style of occupational therapy at my institution then. We have modernized. This is the brand new clinic building that we moved into a couple months ago, which is very exciting. This workout facility is fantastic. So if you're able-bodied, they have these chairs for you. But if you're in a wheelchair, these seats move out, and you move in your wheelchair and you can work on the weight machines. It's a very cool for our spinal cord injury patients. So the problem is, if we're going to do a reconstruction on someone that doesn't have great hand function, you really have to choose wisely if they don't have good support at home. You got to talk to the patient and the family. The family needs to understand this is a full-time job if the family is going to do the catheterization. And we have very significant discussions with them. The other issue is the disease progressive for folks that are doing their own catheterization. That's just probably most looked at with my MS patients. If you can barely catheterize now, is this a good idea to do a reconstruction? What's going to happen in a year or two? To me, if there's any doubt, don't do any kind of reconstruction that requires catheterization. So we always show our successes. I'm going to show one of my many. We all have disasters. This is a gentleman who's C4. We did just a straight augment. We had significant discussions with him and his wife. His wife was going to do all the catheterization. She was up for it, no issues, on board, multiple conversations. Did the surgery, did great. Post-op cystogram, great. Went home, 5 days later, she says, I'm out of here. She lasted a whole 5 days. So Efren did not want me to take his augment down. He liked it. So he did a sphincterotomy. That did not work. So I resected his augment, and soon thereafter, he still couldn't empty, and he actually ruptured out the area where we closed the bladder. We ended up just doing a cystectomy and a conduit. So it doesn't work for everybody. None of us are successful, but so even choosing, we thought we chose wisely, that didn't work for Efren. So we're contemplating surgery. Obviously, we're going to do a full trial of conservative therapy, evaluating the bladder and the outlet. And the questions are, if we're going to do something that requires catheterization, who's doing it, patient, family, caregiver, and where are we doing it? Urethra or a urinary stoma? So who benefits from a stoma? So as I said, whenever I have a female patient, if we're going to do a bladder augment, and all of these surgeries we do much less of now because of botulinum toxin, but if we're going to do an augment, if for a female patient, I always ask, how well can you catheterize, and would you prefer a stoma? With the full disclosure that stomas aren't perfect either, much higher revision rate. So trade-off, certainly a bigger surgery, more complication, but it may ease CIC. So how do we know this? This is one good study, one study I know of. We're trying to look at this now in a prospective manner. Tony Stone's group looked at 6 women that had an injury at C7 or higher, and look at the amount of time saved per catheterization episode when these women transition from catheterizing per their native urethra to now catheterizing through the stoma. So if you catheterize 6 times a day, you've given that patient 2 more hours. That's an amazing amount of time. It's an amazing amount of freedom, however you want to look at it. So I think it's an important discussion to have with all women. How long does it take you to catheterize? And if it's an issue, not even those that have hand function issues, is it worth making a stoma? So management of neurogenic lower urinary tract dysfunction without the ability to catheterize is very challenging. First question always is, can anyone else do the CIC for you? And oftentimes that just is not so easy to get. And if not, I think we're often choosing between a bad option and something that's worse for some of these patients. At least I think they look at it immediately. But if you look at least those mature patients that we showed those quality of life data, either they get used to it, they become content, it works out, whatever it is. But this is sometimes the option. And men, diaper, condom, cath, some type of indwelling catheter. If it's indwelling catheter, it really needs to be a suprapubic or reconstruction. The same with women. There's no condom catheter available. And again, it's not always looked at as an optimal option by our patients. I'm from SUFU, and again, I appreciate the invitation. So I'll finish off just to remind you that our SUFU meeting will be in February in Arizona. For those of you that live in cold areas, Arizona is really nice in February. If you live in Goldberg, it must be cold all the time because this is like a winter's day for me in Los Angeles today, but that's okay. And I'll leave you with one last picture, which is one of our other early rehab pictures here from Rancho Los Amigos. So thank you very much.
Thank you very much, David, for an incredibly fascinating insight and really helpful practical suggestions. Would you mind a few questions?
Absolutely.
Elise?
That's the fun part.
Thank you so much, David. That was a great talk, and we will look forward to SUFU this year. Data on how happy one is after a diversion is kind of like a man with a penile prosthesis. I mean, he would have been happy with Viagra if it had worked, and he's so desperate by the time he gets to the prosthesis, he's just happy he's got an erection, right? So I think it's hard to understand how happy patients really are once they've gotten to the 4th intervention. Suprapubic tubes are not suprapubic tubes are not suprapubic tubes. I find that the larger diameter and a shorter, softer tip that's less likely to cause irritation can be much more effective in preventing problems. And there are so many different subtleties to that more conservative management. Do you have any comments on that?
So I would say, in regards to the diversion, if we're doing a diversion in one of these patients, they've had a lot of prior bad outcomes. So for sure, they're going to be biased. And anyone who's going to, if you're doing a 4-hour surgery on me with a big recuperation, I'm going to for sure be happy afterwards because I don't want the alternative, what can be worse, right? So that certainly is an option. But at least, they weren't unhappy, at least from one way to look at it. In regards to suprapubic, again, I wish I could understand why certain patients do amazing, right? We have patients that have tubes for 30 years, aren't on any bladder meds, they never leak per the urethra, they never get UTIs. and you have a patient with a very similar injury who after a year is having recurrent UTIs, sepsis, leaking per the urethra, even despite meds and botulinum toxin, and they theoretically are the same patient, and I absolutely can't predict that. So no, I mean, all tubes aren't the same, but all patients aren't the same, and I can't predict who's going to do well. You know, certainly if we do a trial, I mean, the nice thing about a super tube is we're not burning any bridges, right? If it doesn't work, you take it out and you
Yes.
move on to the next option.
Right.
So,
Thank you.
I think we're going to have to stop it there, Jilesh. I'm sorry. Maybe you could meet up with David afterwards. Adrian's just reminded me that we're meant to be starting at 12:20. David, thank you very much for a great lecture. Thank you very much.